Good morning, everybody, and happy Monday. I'm going to start off the week with some super fun, light information on underwriting with AFib, or otherwise known as atrial fibrillation. Our reasoning really for choosing this topic was that I see this one probably 4 or 5 times a week minimum. It is something that we encounter quite often. So I thought it would be a good topic to dive into today. Let's see here. And with that, we will just get right into it. So what exactly is atrial fibrillation? I'm sure everyone's at least heard of this before, whether it's yourself, a family member, a parent, a client. It's quite common. So AFib, this is an irregular heart rhythm, or otherwise known as an arrhythmia, and there are multiple arrhythmias out there. AFib is absolutely not the only one. It is just the one that we see the most often. Um, with AFib, this basically, it begins in the upper chambers or the atria portion of the heart. And with AFib, your heart's electrical system, it just doesn't work like it's supposed to. Instead of a steady, regular pattern with the electrical impulses firing like, we see in all the movies, the da-doom, da-doom, da-doom kind of rhythm. This is different. This is many different impulses that are all firing rapidly at the same time. This will cause a really fast, chaotic rhythm in that atria section of your heart instead of that regular rhythm and pace. And then as a result, your atria then cannot do a good job of contracting or pumping blood into the lower chambers or the ventricles of your heart. Your ventricles then respond to your atria. So then they start to contract irregularly, and that causes an additional rapid irregular heartbeat. These ventricles may get up to 140 to 160 beats per minute or signals per minute instead of the normal 60 to 100 that we would like to see. Atrial fibrillation, it is the most common sustained cardiac rhythm disorder in our population as a whole. It represents quite the problem within the entire population with obvious impacts that we're covering today being in underwriting. Currently, they estimate that there are 2.3 million people in the United States with this disease. That doesn't sound very high, probably, but this number is expected to grow more than double up to 5.6 million people by 2050 due to the population aging. So while the 2.3 million number isn't the largest we've seen in some of our different ailments that we've covered, the rate at which it's growing is very problematic, especially in an underwriting capacity. I mean, because obviously we're looking at people as their ages get up and so we're going to see that just continue to increase. So when it comes to atrial fibrillation, it is primarily a disease of older ages. The median age of patients with this condition is actually 75. Personally, I was shocked by that. I thought it would be a little bit younger. I knew it was obviously a disease of older ages, but I see it in multiple ages. So the median age of 75 was a little bit surprising. Approximately 84% of the individuals that do have this condition are over age 65. So again, up there in those older ages. And the incidence rates do double each decade of life. So, if you're seeing this in your 40s or 50s, it's only going to progress. And those without it, we are obviously going to see those numbers still increase. And so if you're in the clear now, that's good, but that does not mean you're completely out of the woods, because again, these increases, they double with each decade. So not something we're all going to get away from, unfortunately. And let's get into what different types of AFib there are, because there are all sorts of different types. They are not all the same. They are not all created equally. When we are looking at AFib, we do classify these in 4 different types. The Most common that I think we see is probably the paroxysmal AFib. These episodes last usually less than 1 week. They usually go away on their own without any kind of treatment. This is the kind of stuff we see in younger clientele, a 40 or 50-year-old that walks into the ER and says his heart's just kind of fluttering out of control. And, so maybe it's energy drinks, too much coffee, these kind of things. We can see doctors that will recommend less caffeine and such to kind of get this under control. This can come with symptoms. They may just feel a little unwell during these short periods of AFib. Sometimes it's just a little lightheadedness or a little bit of fluttering, but it's not always something that's real obvious, I guess is my point there. With persistent AFib, these usually last more than a week. They generally do need some kind of specialized treatment to either slow the heart rate down or break that rhythm and get it back into a normal sinus rhythm. But those then typically are cured, so to speak, or at least controlled after such treatments. With long-term persistent AFib, this usually lasts more than a year, and this is more difficult to treat. These are the ones where we see the long-term medications. And then with permanent AFib, this is obviously, as the word indicates, it's permanent. It's not responsive to treatments. It's not going away. And this is after multiple treatment attempts. This isn't something that's just determined, on a first visit by any means. Okay, so what are some of the risk factors? Who are we seeing this in? There are a number of risk factors that can increase the risk for developing atrial fibrillation. The factor that's responsible for the largest number of cases, primarily just due to its high relevance, is going to be hypertension. Anytime we see AFib, we almost always see it combined with hypertension. Again, I won't say 100% of the time. Some of the younger people, maybe it's, like I said, those energy drinks, that caffeine, something along those lines. But for the most part, if you see one, you see the other. Other cardiovascular risk factors that we take into consideration are going to be diabetes. This is going to be a big one, metabolic syndrome, obesity, and then some of the other more common cardiovascular diseases can come into play as well. So the risk for developing AFib is increased with all these different cardiovascular diseases, including but definitely not limited to. Congestive heart failure is a big one, myocardial infarction, otherwise known as a heart attack. That can definitely increase your risk, and then valvular heart disease will increase that risk as well. There are some structural heart issues that can cause an increase in risk there. That will be like the mitral annular calcification, a left atrial enlargement, which is typically seen on an echocardiogram. It's not something that anyone's just going to know that they have. These are a lot of things that they'll pick up on testing. Another one being left ventricular hypertrophy, or just by abnormal EKGs, echoes, ECGs, and such. And so while hypertension is the most common causal factor throughout the population, coronary artery disease and heart failure are more common in the hospital-based cases. So while we see all of these, we see them in different areas, and how that will affect their risk there. Other risk factors that you might want to keep in mind is being male. You have a 1.5 times more chance of developing AFib than females. A history of cerebrovascular events like a stroke or a TIA, those are also going to increase your risk of AFib. The presence of hyperthyroidism is another big one that a lot of people don't realize. And any condition that's going to produce inflammation, like if you're post-surgical or something along those lines, that can also increase your risk, as will obstructive sleep apnea and elevations of your pro-BNP levels. Now, the pro-BNP levels, that's something that we typically see in your insurance labs. A lot of doctors' offices don't even run that test on a regular basis unless they've been given reason to. But it is something that insurance companies run on a regular basis. They will run this pro-BNP depending on the client's age. Um, some carriers will do it right away based on age and face amount. And for the ones that don't, they can go back and ask the labs to run that lab after the fact if they have reason, if there's cause for concern, if they see something in the history and they want to know where that pro-BNP level is, they can go back to the lab and have that run after all the original labs were done. So it does not require an additional blood draw typically, unless there was something wrong with the blood draw. Like I said, they can usually just use the labs they have. When they're looking at that pro-BNP level, they're looking for indications of heart failure because that test is indicative of heart failure once it hits certain levels. So just kind of a little background on what that pro-BNP is. Sorry, didn't have a slide on that. Just wanted to throw that in there. Okay, so what are some of the symptoms that we're going to see? They're not as obvious as you might expect. So the most common symptoms that are associated with AFib are going to be palpitations. That's the one that we see in the records the most often. The next most common is fatigue. It seems to wear people down. They just don't feel good in general. Lightheadedness is another one. Exertional dyspnea, or difficulty exerting all that air out of their lungs. And sometimes it's just very non-specific complaints. It's just, I don't feel good. I just feel worn down. I just feel tired all the time. Sometimes it's just very non-specific, and that's how it comes to be discovered. That's probably the most common one I see. Other symptoms can include chest pain. And for those with angina, which is chest pain, these symptoms may worsen with an increase in that heart rate. So while many people are asymptomatic, the ones with chest pain can see an increase in those symptoms with the increase of the heart rate. Let's see, shortness of breath, again, another one. Edema or swelling of the legs. You might see some extra fluid retention around the ankles and such. However, just keep in mind, many individuals are asymptomatic despite that irregular rhythm. They may not have any idea at all. One of the other things I do see sometimes is syncope or near syncope, which is really just code for fainting. If you stand up too fast and you get lightheaded and almost faint, that kind of thing. Let's see here. We went over this. It can be worsened with angina. Sorry, I was a little slow on my slides there. And again, most cases are asymptomatic. One of the things of note is that with a proximal AFib, that is the least symptomatic. So the most common form of AFib is the least symptomatic of all the AFib. So just a little side note there. Okay, so how does this increase our mortality risk? Well, multiple studies have indicated an increase in the mortality risk. The pattern of the increased mortality has persisted over time. It's remained unchanged, even with all of the different tests, procedures, treatments. Over the last 20 years, it doesn't matter. It still has remained unchanged that it does increase the mortality regardless of how we're addressing it. The mortality risk, interestingly enough, is its highest in the first 4 to 6 months after diagnosis. And so this is a good indicator of why we see so many postpones and declines within that first 4 to 6 months. A lot of times, if we have a history of AFib that has presented itself, the carriers will come back and postpone until they're past that 6-month date. And until treatment has really been leveled out, figured out, they know exactly what's working and what's not, and we're not seeing a bunch of medication changes there. And then even after that 4 to 6 months, the mortality risk is still increased for that individual, just not as much as it was in the beginning. And of course, chronic AFib, one that is permanent or chronic, is going to carry a greater risk than one that is just temporary. And age of onset is obviously a major determining factor. There was a clear difference in survival between those that were less than 45 and that those were more than 45. The older individuals actually they had a significantly higher risk of death, stroke, and progression to chronic disease as that presented itself. All right, so next we're going to get into a few of the things we see commonly here. Um, with lone AFib, this typically will come in with someone who's under 60, who's had no other risk factors. They have no other increased mortality. Um, it's kind of a once and done, and those are usually treated fairly easily, can be brought under control. However, what they're finding is that after 25 years, they've followed a lot in these studies, they followed these patients and found that even though it was resolved, 25 years later, they were seeing an increased cerebrovascular risk in all of these people that had this history compared to the rest of the population, which did increase their risk of a TIA or a stroke. So that lone AFib doesn't really fall under the 4 different types, but it's just worth noting that 1 or 2 incidents really can make a big difference in the long term, even if you don't see it right away in the short term. Up to 29% eventually did develop chronic AFib. So just kind of something to keep in mind there too. When you have a client who's upset because everything's resolved and the doctor says they're better now, again, doctors are looking at morbidity. They're looking at how you feel at the moment. They're not looking at your overall mortality like the underwriters are. The underwriters are looking to see how this is going to affect your mortality long term, not how you're feeling today. So they have to keep in mind that even though this was resolved, there is still this increased chance of it coming back or coming back worse. All right, and then just another little side note there is that AFib developing during the first 72 hours after a heart attack does have a much poorer prognosis than if it develops at any other time. All right, so one of the big mortality considerations that we do have to look at when it comes to AFib is the possibility of a stroke. Atrial fibrillation, it significantly increases the probability of a stroke with a 4 to 5 time increase compared to the general public without any kind of arrhythmia. And it will account for about 45% of all embolic strokes, are those caused by an embolism. So one of the ways that we can assess the risk of a stroke in individuals with AFib is going to be a CHADS score. I mention this CHADS score because this is something we look for in the medical records anytime we are underwriting an AFib case. This score, it assesses all the most common risk factors that come with AFib. So congestive heart failure, hypertension, your age being over 75, diabetes, and a stroke. So these are the things they're going to look at. And what it basically does is it's going to assign 1 point for each of those first 4 factors. So it'll assign 1 point for congestive heart failure history. It'll assign 1 point if you have a hypertension history. It'll assign 1 point if you're over age 75. If you're not, then it doesn't get a point. And then it will assign 2 points for that last indicator being the stroke or the TIA. So if you've had a stroke, they're going to give you 2 points on top of that. The higher the score, the greater your risk is for a stroke, is what it comes down to. Additionally, the presence of AFib itself will increase that risk beyond any of these conditions contained here in the risk score alone. So this is something, again, we look for in those records is that CHADS score. And the higher the score, the higher the risk. And then we get into congestive heart failure, which is the other closely linked issue with AFib. The presence of congestive heart failure, it basically it increases the risk of developing this arrhythmia. On the other hand, the onset of AFib can precipitate heart failure in those with who already have a marginally compensated ventricular function. So one can cause the other and vice versa. It's kind of who came first, the chicken or the egg. We really have no idea sometimes. But it can cause even more life-threatening ventricular arrhythmias that are different than AFib. And so they really watch for this congestive heart failure, which again goes back to that pro-BNP lab. A lot of times when the companies are running that, they're looking for signs of heart failure because this obviously can complicate matters tremendously. And then when it comes down to it, treatment has to address everything. It has to address the rhythm issues. It has to address the overall cardiac health, and it has to address the heart rate. So there's all sorts of things that they're going to have to look at when diving into this. So what tests and procedures do we typically see, or are we typically looking for, the doctors doing? And how we're finding out whether or not we have AFib. Okay, so the first most common and the standard for any kind of diagnosis is going to be the electrocardiogram, otherwise known as an ECG. Some people will call it an EKG. Either one, the doctors and underwriters know exactly what is being spoken of. The ECG, if just for reference, is the test where you see all the little squiggly lines. This is where you see your T waves and S waves and all those different cardiac rhythms there. So this is where they're going to identify any kind of AFib. The next most common one that we're going to see and be looking for is going to be the echocardiogram. The echocardiogram is basically an ultrasound of the heart. I know a lot of people get the EKG and the echo confused, and that's why I'm kind of pointing out what they are, because there is a big difference in the two. The electrocardiogram is getting the rhythm, the echo is getting the images. And this is, again, going to look at the size and function and all sorts of different parts of your heart to make sure everything is doing what it's supposed to be. The stress test is another one that we may look for. This sometimes you'll see listed as a treadmill stress test. This is, where they put all the stuff on you and have you walk or run and see how your heart reacts. We also have the cardiac cath. This is where they examine the blood vessels in the heart. A lot of times this is the one where they'll go up through the groin and go in and just make sure there's no blockages and look through and make sure everything's working the way it's supposed to be. And then last but not least, thyroid function test. A lot of people, again, don't realize that hypothyroidism is a big trigger for AFib. And so if you are out of rhythm, a lot of times doctors will run your thyroids just to see kind of what that's looking like. So when it comes to the treatment of AFib, the treatment can be broken down into therapy that's aimed at the arrhythmia itself, and they can also look at aiming towards preventing complications, specifically an embolism or a stroke. Both of these matter, and they're both kind of tackled different ways, if you will. So control of the arrhythmia can be done a couple different ways. They can control the rhythm itself with some kind of conversion to a sinus rhythm, whether this is with medication or with like an ablation procedure. They want to control that heart rhythm and get it back to where it's supposed to be in. The other thing that they can do is focus on the heart rate. And the heart rate control is what they prefer in individuals typically who are over age 65 those who have had a cardioversion, people who cannot tolerate the anti-arrhythmic drugs, then they might have to focus more on rate control than they do on rhythm control. And if they don't have heart failure. Now, if they have heart failure, we're in a whole new ball game there. The mortality outcome really is the same whether you're looking at rhythm control or rate control, but the rhythm control group has a much higher hospitalization rate. So that's just something to kind of keep in mind there and there as well. Rate control can be accomplished with a lot of different ways, a lot of different drugs. There's several drugs for this, a lot of beta blockers, calcium channel blockers. Digoxin was a big one, but digoxin takes longer to work than the other medications. And it doesn't control some of the other heart rates as well as the other drugs. And it has a lot of side effects and has had a lot of drug interactions. And so because of that, we actually don't see it used near as much as it used to be in the past. Um, Conversion to a sinus rhythm um, can usually be accomplished usually using medications or the electrical cardioversion. Um, Pharmacological treatments usually work best in the first 24 hours. Thereafter, its effectiveness kind of diminishes, and so it's not used as much. The use of drugs has the advantage of helping to preserve that sinus rhythm once it's established, and if that cardioversion was successful. The disadvantage is that some of these medications can actually promote other serious arrhythmias. Additionally, there's side effects with a lot of medications that are pretty common. So, when I talk about the postpone period or the decline timeframes, a lot of this is so that they can get everything under control. It's not just as simple sometimes as getting the right rhythm. We got the right rhythm, now we've got to get it back down to the right rate, or vice versa. And so this is why we do see a lot of those postponed. So they do want it typically to see that the client has been well controlled with no medication changes and no significant side effects for a minimum of 6 months, regardless of what their exact diagnosis and symptoms might be. All right, so what does that mean for underwriting? What are we going to want to see? We will definitely, absolutely, 100% want to see a current EKG or ECG. With that, I hear it all the time from clients. He had one last year. They want a current one. If the arrhythmia was diagnosed 6 months ago and an EKG was done at that time, they're going to want to see that EKG and a current one. It's not, excuse me, it's not always going to be enough just to see the test that was done when it was diagnosed. They're going to want to see the follow-up EKGs to make sure that it is now in a good sinus rhythm. They're going to want to see a full APS, not just that test and not just cardio records. It's oftentimes imperative that we get both because, the cardiologist, they're going to have all the cardiac records we want. And they're going to have all the testing, and that's great. But they're not necessarily going to have the rest of the story. And so we need to be able to look at that complete history and see, is there diabetes? Is there hypertension? Is there hyperthyroidism? Is there a strong family history? Yes, some of this may be in the cardiac records, but a lot of times they don't have the full story. They only have the cardiac story. And so, we'll have an agent here or there that'll just send in cardio records and think this should be enough. Let's get it pushed through. And when we have to sit and wait for the PCP to send in their history as well. So we will be going after all of that. Again, the blood profile specifically for that BNP reading that we've talked about. There's obviously other things that they're going to want to pull from that blood profile, but that pro-BNP is a big one. A lot of times we will see cases postponed because an underwriter wants to see an echocardiogram. Now this gets frustrating, I understand, for agents and for ourselves here. If the cardiologist has not asked for an echo, then why in the world would we be telling our clients to go get an echo? This boils down to and goes all the way back to the way doctors and underwriters view things differently. Doctors, again, are looking at morbidity. They want to know that you feel good, that you have no symptoms, that you're doing okay day to day, and send you on your way happy and healthy with, whichever medications are working at that time. Um, and so they may see a favorable ECG, everything else looks good. You go into your doctor, you tell them you're feeling great. And so the doctor says, okay, well, we're just going to leave well enough alone. And they've pretty much released you back to your primary care provider. And, you just have to come see the cardiologist once a year or so. But then the mean underwriter comes in and says, no, we want to see an echo that nobody else asked for. The echo is a huge indicator in how all of the different parts of the heart are functioning. If there's any calcifications, if there's any blockages, if the blood is pumping at the levels it's supposed to, they want to see an ejection fraction up over that 55, percent range. They don't know any of that without seeing the echo, and that can make a huge, huge difference in whether or not this client is standard or a decline. And so oftentimes they will postpone or even decline until an echo has been done. Um, I know that does get frustrating for the clients. It does get frustrating for the agents. But at the end of the day, the underwriters, they are signing off um, on these face amounts, and they're looking at morbidity. They're looking at mortality. I'm sorry, they're not looking at morbidity. They're happy that you feel fine, and that your morbidity is fine, but that mortality has still been affected, and they need to know to what extent. And they don't necessarily know that until they can see that echocardiogram. So they need to be able to tell, is there enough blood pumping properly? Is that ejection fraction where it's supposed to be? Is there a major blockage? They need to see those things in order to rule anything out. Um, at the end of the day, if you walk out of the doctor's office and you say you feel fine, and your doctor says, great, everything's wonderful, and a week later, you don't feel fine anymore. Your doctor can change course. Your doctor can prescribe new meds. Your doctor can do new tests. He can do new procedures. He can completely change everything that's been occurring to whatever's going to best suit your needs. However, the underwriter cannot. Once they have, given an approval and gotten a case in force, they can't make any changes a week or 2 weeks later. So if all of a sudden you don't feel good anymore and you do have an echo and it turns out that it was worst case scenario, the underwriters can't pivot. So they have to be very proactive upfront in making sure that they really see the mortality for what it is and not just how the client was feeling at their last visit. I know that sounds a little harsh, but that's the reality of the difference between that mortality and morbidity approach. Okay, so those are the things that we're going to want to see. And so here's just a couple examples of what we've seen here recently. Like I said, I see these AFib cases multiple times per week, so I grabbed a couple that I thought were a little bit interesting. This first one we have a gentleman, 56 years old, and he is a regular marijuana smoker. His irregular heartbeat was not diagnosed until this year in February of 2025. He had a completely normal stress test and EKG done in 2024. So just, what is that, 8 months earlier? And then all of a sudden this heart rhythm came up. He's on a couple different medications, one of them being this lisinopril for high blood pressure, which, by the way, can also be used for heart failure. So a lot of times when you're listing these medications, definitely list what it's for, because an underwriter looks at this and they don't know if it's high blood pressure or heart failure. Most of the time it's going to be high blood pressure, but a lot of times we have to ask because, we don't want to make assumptions and find out that we made an offer on a case that we shouldn't have because it was actually heart failure. And then he is also on this Midorone for an irregular heartbeat. This is an antiarrhythmic drug. This is not one of the first lines. It's usually after some of the other medications have not worked. So it's one of the stronger ones for AFib. With this one, we had multiple carriers that did decline. Part of this being there wasn't enough testing to review at the time. We did need to see more. Part of this being that there was a combination of that marijuana smoking. They did not like seeing that he was a smoker with AFib. However, even with all those declines, we did have one company that came in at table 6, which wasn't bad. Then we had a couple that surprised us at table 2, so we were feeling pretty good about that. And then we had one outlier who came in at standard. That did require that the client go get that testing that was missing, but we were able to place that case at a standard rate. All right, and one of our other interesting ones here. We have another gentleman, 62 years old. This young man was a non-smoker, so we're doing a little bit better out of the gate there. His build was good. He was 5'9", 205, nothing totally out of control there. He was type 2 diabetic. It was well controlled. There were no complications. His A1C was good, so that all was favorable to him. He did, of course, present with hypertension, as we indicated we typically see. So for him, his history was a little bit more detailed with the AFib, though. He was diagnosed back in 2014, and over the next year, he had 2 different ablation procedures to try to get things under control. And then in May of 2015, he had a stroke. The stroke, luckily, was a mild one. He is not on any medications for this stroke. And there were no residuals. There's no complications afterwards. And so he's made a full recovery. They suspected that the stroke was caused by Xarelto, or the blood thinner that he was taking for his AFib. So like I kind of pointed out before, all these things keep interacting with each other, and what medication works for patient A may not work for patient B, and this is why we a lot of times see those postpones, because we've got to see how things are going to work themselves out. Now, this young man, we once again ran into almost all declines. However, he did see his doctor on a regular basis. All the follow-up testing had been favorable, and we did have access to all of the testing that the underwriters were going to want to see. So as we shopped this out, yes, a lot of them did come back and decline. However, we did have one company that came in at a table 4, and this other company came in and surprised us at a table 2. So we were again able to place it. But I point this out because you see one case get declined, and it's really easy to jump to the conclusion that your next case like this is going to get declined. And they are all so very, very different and unique. And there's so many little factors that are taken into consideration that I just implore you never to jump to that conclusion. Give us a call. We can shop those out. I can reach out to the underwriters. I can read through the records and summarize those for the carriers so that we can get good tentative offers up front and know exactly which companies are going to be worth sending an application to and which ones are going to be a complete waste of time. So that I kind of got ahead of myself there on the how IAMS can help. Definitely reach out, give us a call. I have hundreds of these cases in my quick quote shopping history that I can go through and compare and look for cases that are very similar to yours. And obviously we can shop each of these individually as the information is provided to us. We have our fact finders that are out on our website. You can go to iamsinc.com, and we have a couple different things. We have a very generic health screening questionnaire that covers everything. It covers, driving history, travel history, foreign national history, criminal history, financial history, medical history, a little bit of everything. And this is a good snapshot of our clients as a whole so that we can dig in. And then if we need to dig a little bit deeper, we do have more ailment specific pre-screen questionnaires, whether it's cancer, AFib, any other disorder. We've got the NAILBA guide that allows us to have these questionnaires filled out and then shopped based on the client's very specific history. Those are again on our website, or you can email me for any of those that you may need. You can reach out to your sales director. You can send any pre-screens directly to me at andrea@iamsinc.com. The more information you can give me, the better. You can reach out to your sales director and give them the information and they will get it over to me, or you can just send it to our regular pre-screen box. It's just pre-screen at iamsinc.com. But definitely, I do recommend incorporating those health questionnaires. They definitely save a lot of time on the back end of things. I know they can be a little cumbersome at the front end of things. Nobody likes going and asking 100 million questions, but it can save us a ton of time when it all comes down to it, because then we know which carrier to work with and we're not trying to pivot after the fact and after the client is frustrated. So with that, I do thank you for your time today. Don't forget to follow and like us on Facebook and LinkedIn. And if you have any recommendations or requests for future webinar topics, please don't hesitate to let me know. Thanks so much. Talk to you again soon.